Welcome to the Illinois Perinatal Quality Collaborative Labor Management Support e-modules. These e-modules were made as a resource to support hospital implementation of the ILPQC Promoting Vaginal Birth, or PVB, initiative. The aim of the PVB initiative is for 70% of Illinois hospitals to be at or below the Healthy People 2030 goal of 23.6% cesarean delivery rate among NTSV, or nulliparous term singleton and vertex births, by December 31st, 2022. Our goals include increasing the percent of C-sections among NTSV births that meet ACOG SMFM criteria for cesarean, as well as educating physicians, midwives, and nurses on ACOG and SMFM criteria for cesarean, including labor management strategies. Hospital quality improvement teams participating in the PVB initiative are working on 5 key strategies to reduce cesareans among NTSV births, including labor management support. ILPQC partnered with Jessica Brumley, the co-creator of the Florida Perinatal Quality Collaborative, or FPQC, labor support workshops, completed by over 400 nurses and providers in Florida as part of FPQC's Promoting Primary Vaginal Deliveries, or PROVIDE initiative. Jessica is Director of Midwifery at the University of South Florida Department of Obstetrics and Gynecology, where she leads a team of 14 midwives and advanced practice nurses. She also serves as an advisor on the FPQC PROVIDE initiative. In August and September of 2021, Jessica and ILPQC worked together to offer 2 live virtual labor management support courses for nurses and providers in Illinois. These sessions were recorded and broken down by topic into this collection of 14 e-modules ranging from 6 to 21 minutes each. We are excited to share them with you. Now I will turn it over to Jessica.
Okay, we're gonna push it real good. Everybody envision their best salt and pepper. We'll use the same format as we have before. And so I just wanted to go over what is the definition of arrest in the second stage. Before diagnosing arrest of labor in the second stage, if maternal and fetal conditions permit, allow for the following: at least 2 hours of pushing in multiparous women, at least 3 hours of pushing in nulliparous women, and longer durations may be appropriate on an individualized basis for things such as epidural and or fetal malposition, as long as progress is being documented. So typically, people will add an hour to all of the numbers for someone with an epidural. And again, that keynote of progress being documented. California has this algorithm for management of the second stage, which I like because it talks about kind of what each person does at each stage, right? So at 1 hour of pushing in, in a person, in a nulliparous person without an epidural, if there's no progress, the RN to SPART provider, CNM or MD to evaluate patient and document plan of care. If they're a multip, CNM to consult MD, MD to evaluate patient and document plan. So just making sure that there's clear communication. I think it's really easy to get into a room and start pushing with someone and kind of just get lost in like that sort of like labor land, and you come out 4 hours later like, oh my gosh, it's 7 o'clock, like the night team is here. So being sure that you're communicating along the way, and again, for someone with and without an epidural, they've talked about it. This is the labor dystocia checklist for California, and it's just kind of going through no descent or rotation for at least 2 hours with a multip without an epidural, 3 hours with, 3 hours in a nullip without an epidural, and 4 hours in a nullip with an epidural. So did you meet that criteria before you call a C-section for that indication for arrest? As we were doing these workshops, we received a lot of questions about laboring down, passive descent, delayed pushing, whatever you want to call it. Um, and, um, and, you know, it's because obviously it's a technique that, we can use. Delayed pushing is a period of rest between full dilation and the active urge to bear down. And in somebody without an epidural, it sort of just kind of, happens naturally. We often don't even know about it because we haven't sort of checked them until they feel that urge to bear down. But that passive descent allows for descent and rotation. And it was previously recommended by ACOG, ACNM, and AWAN, and is found to be especially useful in people with an epidural, since that diminishes the urge to push when the station is a bit higher, or if there's a malpositioning, or the woman's just really tired. In 2018, Calhill published a randomized controlled trial comparing immediate versus delayed pushing in a group of over 2,000 nulliparous women at term with an epidural, so really specific to that patient population. And they found that there was no difference in the rate of spontaneous vaginal delivery, and the spontaneous delivery rate was not affected by station, position, or study site. There was no difference in the rate of operative delivery or C-sections, and this sort of composite outcome of neonatal morbidity, which includes a bunch of things that are not super common, like meconium aspiration or suspected neonatal sepsis. But in the immediate pushing group, there were lower rates of choreo, lower rates of postpartum hemorrhage, a shorter second stage. Obviously, there was a longer mean duration of pushing, but it was only like a 9-minute difference, so not really clinically significant, although statistically significant it was. There's an increased risk of 3rd or 4th degree lacerations, but lower rates of neonatal acidemia. So because of this study, that was a well-designed, large randomized controlled trial that showed lower rates of choreo and lower rates of postpartum hemorrhage, and no improvement in cesarean section outcome data. ACOG released a practice advisory that recommended that women begin pushing once cervical dilation is complete. And a lot of the nurses that I was working with in these workshops were like, I mean, what's going on? All of a sudden, they're just saying you got to push right away. And this was a big change in practice. The position from ACNM was that they endorsed the practice advisory, but acknowledged that more research is needed and that this is not a recommendation for a new standard of care and cannot replace individual clinical judgment. So that being said, basically, it's okay to individualize the care that you give, that this is one piece of information, but maybe not everyone needs to have delayed pushing or laboring down, as was happening, at one time. So there's one piece of the evidence. What other evidence do we have about second stage that we can review? Just like in first stage, in second stage, changing position is best practice. For women without an epidural, pushing in an upright position is associated with a decrease in the risk of episiotomies, operative vaginal deliveries, fetal heart rate abnormalities. There may be an increased risk of second degree tears and a possible increased risk of having blood loss more than 500 mLs. And that was actually mentioned in that video from the parenting channel. Standing, kneeling, squatting, they all take advantage of gravity, help the baby move in the pelvis, increasing the diameters of the pelvis, and birthing in the sideline position has been shown to reduce perineal tearing by allowing the presenting part to descend more slowly. They could also just kind of a little bit diminishes that urge, that really strong urge that you feel when you're in a more upright position. So like squatting and standing, the dimensions of the pelvis can be maximized by the hands and knees position that's often used to relieve back pain that may occur when the infant remains in that persistent OP presentation. women can benefit from frequent position changes and should be free to select or reject them at will. So laboring down, maybe not. Position changes, yes, that should be something that we're using consistently. And then type of pushing, right? So open glottis pushing, right? So that like grunty, make a noise when you bear down kind of pushing, closed glottis pushing, hold your breath. Some people call it purple pushing, right? Push for as long as it takes to count to 10. So this like open glottis or non-directed pushing is maybe used sometimes for people without an epidural. But I think a lot of people have gotten to a place where it's been all about the directed closed glottis pushing. And research does not support the widespread practice of directed pushing, which has been shown to stress the maternal cardiovascular system, reduce circulating oxygen, and trigger changes in the fetal heart rate. So it's more stressful for mom and for baby when we push this way. Women who are encouraged to push in coordination with their perceived urge consistently limit efforts to short bursts of 5 to 7 seconds and often grunt, groan, or moan, releasing air through an open glottis. So this practice improves oxygenation, obviously, and it also is less stressful on the pelvic floor. So directed pushing can increase the risk of urinary incontinence later in life. And one study showed that directed pushing shortened the second stage of labor by an average of 13 minutes. So, I mean, not actually probably a clinically significant difference. And that open glottis pushing results in better maternal fetal circulation, less maternal fatigue, and less chance of bladder and pelvic floor and perineal damage. So this is a more physiologic way. We can support people in bearing down spontaneously, however feels right for them. When they feel the urge, obviously they have to feel an urge. And again, this is usually more pushes, but shorter periods of time. And I always tell them it's okay to make noises, just kind of like moaning. But there are obviously times where we need to do sort of the old-fashioned directed pushing. If you've tried the open glottis pushing and they just kind of can't get the hang of it, sometimes people need direction, encouragement, coaching. When pushing is continuously like uncoordinated, if women have an epidural and they've labored down and they just feel nothing, if we're at a point where we need to be performing an operative vaginal delivery, then we just got to get this baby out and we have to do it as fast as possible. So those would all be reasons to do the closed glottis pushing. So how do you do open glottis pushing? So the provider or the support person is there to just encourage the laboring person to trust their body, right? Just push as you feel right to push. Whenever you feel the urge to bear down, just like when you're having a bowel movement, most people take several breaths between pushes. That's okay, right? You don't need to like rush them into that next push. And you probably will push for about 5 seconds, 3 or 5 times. You may grunt or make a deep noise when you're pushing. This is a sign that you're pushing well.